Okay, welcome to the first mini lecture for the block. And here we want to talk about psychosocial aspects that we consider in the patient interaction with patients with spinal dysfunction. First thing that I want to do, though, is sort of set the context for this. And as we think about how we interact with our patients during that initial examination, there's a strategy that I would like you to consider adopting that will work well for you in organizing your thoughts. And the first step, and these should be familiar to you, the first step is that we always want to rule out serious pathologies. We want to do that first step in differential diagnosis, kind of a systems review, making sure that there are no red flags just as was defined in MC last year. The second step when we're dealing with patients that appear to present with spinal dysfunction is we want to make sure that there's no progressive and significant neurologic impairment, because as you're aware from neurophysiology, if we have prolonged compression of peripheral nerves or neural tissue, we can start to see degenerative changes and eventual loss of function as it relates to that neurologic impairment. So we want to screen for that. It's not a point at which we stop our examination, but it may tell us that we need to refer that patient off for a neurosurgical consult related to that. And then the last thing is we want to start thinking about psychosocial emotional factors that our patient presents with that is going to have an impact on our diagnosis, our prognosis, and our intervention with that patient. Critical point here, we're going to call those yellow flags. What I want you to do is get away from the thought that, like a traffic signal, red means stop, ooh, serious pathology, refer them out. Green means go, hey, this is a good patient for physical therapy. And yellow, ooh, somewhere in between, watch out, this could turn into a red flag. What I want you to think is yellow flag is proceed with caution. Be aware. There's some point of concern going on here. And I'm sorry about that system sound if you heard it. But yellow flags just are a point for concern, but they don't stop our interaction with the patient. So let's start to explore some of this. So two patients, and I'm going to just give you a scenario to start to illustrate this. Two patients present to you with an acute sprained ankle. They have similar history and findings. So you go through your examination and you could barely discern patient 1 from patient 2. They look very much similar, your typical ankle sprain. But as we follow their course, patient A, and this is probably something you've experienced, they kind of laugh at using an assistive device for their sprained ankle. They work hard at their exercises, they recover in a week, and they return to all their activities. This is probably you or a friend or a patient that you've seen. This is very common. But patient B, they use 2 crutches for 4 weeks. They start to progress to a cane for assisted ambulation. They have severe pain. They avoid activity and exercise. As a result, they start to have disuse atrophy. They develop some disuse osteoporosis. They're unable to work, and before you know it, they end up on Social Security disability insurance, and they can't go back to work. Sounds unlikely, doesn't it? I mean, most of the patients that you can imagine or have seen end up on this patient A kind of example somewhere in there. And very rarely have you ever seen a patient with an acute sprained ankle go down this course of recovery or lack of recovery. So it sounds unlikely. But what happens if I change ankle sprain to lumbar strain? And now you may say, well, I've seen that before. I've seen a patient presents with just what looks like a common backache, all of a sudden to end up on complete disability and unable to return to work. What's the difference? What's going on here? So here's a question for you. Which man is worse? So in this picture, we have a gentleman sitting in the chair. He's got a lumbar corset on, if you can see that. He's using a walker for assisted ambulation. We have another patient that's in the hospital, and he's giving him some assistance to stand up to his walker. One patient was admitted for surgical biopsy of a spinal infection. One patient hospitalized for ordinary backache. Here's your challenge. Which is which? And if you're on to me, you've probably figured out, yes, the gentleman sitting down, he was hospitalized for ordinary backache. the gentleman standing up providing the assistance, he was admitted for a surgical biopsy of a spinal infection. So what causes the difference? Why would one person respond to what seems like a minimal problem with a lumbar corset and an assistive device and needing assistance to stand, while the one that seems like a more significant, serious problem seems quite mobile, quite active, and is in fact providing assistance to somebody else? And the answer is illness behavior. And you've probably observed illness behavior unbeknowingly between your friends and family. And the way that people respond, and a good example is to the stomach flu. You get that stomach ache, maybe you're throwing up, and you've got that cramps in your stomach. And one person is in a fetal position on the bed, and they're moaning and groaning and just acting out in their pain, while somebody else might be suffering through it, going to class, studying for their exams, and continuing on with life as they know it. So there's this observable difference in how people respond to illness, and that's illness behavior. So the first thing to recognize is it's normal and it's reasonable. People will have a behavior in response to illness or injury, and that's normal. And as we've said, it varies from individual to individual, so not everybody's going to respond to an illness or an injury the same. And then it's important to recognize that when you observe illness behaviors, to realize that it doesn't indicate that a patient has a psychological problem versus a physical problem. It is the behavior that they adopt in response to illness or injury. And it's a component of every patient. It's just that it may be much more observable in one patient compared to another, but every patient has an illness behavior. And it's your job to observe and consider its impact on your diagnosis, your prognosis, and your intervention. So it's something that we do with all patients. One way to observe this is through a pain drawing. You've probably asked patients to complete a pain drawing, be it for back pain or neck pain or a peripheral joint issue. So you're familiar with these. But what we have here is a pain drawing, A on the left and B on the right, from patients that both have an S1 disc prolapse. Okay, so picture 1 or picture A, this patient is drawing or indicating symptoms that would make sense and follow an S1 kind of dermatome or pain pathway. And so it seems to be an accurate and anatomic reflection of low back pain and S1 disc issues. Patient B, or picture 2, is again an S1 disc prolapse from another person, but a significant difference in the way that they represent their symptoms. In patient B, or patient 2, this patient is clearly indicating back pain, but they're also indicating symptoms in both lower extremities, entire lower extremities, and in fact they have symptoms that extend outside of the leg and form a halo around the toes. So significant difference in the way the two represent their pain. And this may indicate or suggest an over-exaggeration of symptoms in an attempt to communicate to you how much the patient, he or she, is suffering. And so it begins to be a beginning indicator of that patient's illness behavior. And so some things that we could observe is that the patient is telling us that their symptoms are over a very diffuse area. Their symptoms are often outside of the body. And some may say, well, that's just an accidental type thing, but they're trying to emphasize how significant and serious their symptoms are. And so it's an emphasis on severity. But it's important to realize that both have a physical basis for their pain. They both have an S1 disc prolapse. You're starting to observe differences in illness behavior. And so we need to talk about behavioral symptoms. And so a lot of times our clinical diagnosis in these patients with spinal dysfunction depends on us recognizing common patterns of signs and symptoms, similar to picture 1, and they represent anatomical and mechanical explanations for their symptoms, versus the patient that may on occasion give us descriptions of symptoms that are vague, not very well localized, or they lack relationship to time or activity, or they contradict normal mechanics, it's just hard to make sense out of what they're telling us. And so there's kind of non-anatomic explanation for their symptoms. So we start to call this abnormal behavioral symptoms. And there's a whole variety of things that you may observe that indicate abnormal behavioral symptoms. First one would be pain at the tip of the tailbone without direct injury. So it's difficult to have coccygeal pain without falling and landing on the buttocks and direct impact or trauma to the tailbone. So patients that report that, that would be an abnormal symptom. Patients that report whole leg pain or whole leg numbness or whole leg giving way are indicators of abnormal behavioral symptoms. Patients that tell us they haven't had a period of time that they've been pain-free over the past year. And that's not an uncommon response to that question. I've had this pain for 1 year, 2 years, 3 years. Patients that report an intolerance to many and all treatments. Patients that have emergency admission to the hospital for ordinary back pain. So these are, when you start to see these, you start to wonder this patient's illness behavior and whether it's becoming abnormal. One method with patients with low back pain of trying to determine whether they have non-organic, or meaning there's no physical basis for their symptoms, would be using Waddell's signs. And you may have seen this or heard about this in the clinic. So Waddell's signs would be that they have superficial tenderness. So when you're palpating the lumbosacral spine, and again, this is really designed for patients with low back pain, that they have superficial tenderness. That they have non-anatomic tenderness. So with your palpation, they're giving you points of tenderness that don't really make sense based on your knowledge of anatomy. They have pain on axial loading. And so the patient, for this test, they're standing, and you apply a bilateral axial load force through the shoulders, straight down towards the floor. The patient will interpret this as, oh, that should hurt my back, so I'm going to give you a painful response, when in fact the amount of force you can apply at the shoulders with its axial load at the lumbar spine is so minimal that it shouldn't cause or increase symptoms. So when they tell you that increases their pain, that would be a positive. Pain on simulated rotation. So for this test, the patient is again standing, and we're going to simulate rotation of the spine by taking hold of their shoulder and hip on one side and encouraging a rotational movement that really occurs at the hips. And if they give us a painful response, that would be a positive. And it's important with this that you make sure you're simulating rotation and not inadvertently causing spinal rotation. A positive distracted straight leg raise. So from MC, if you're familiar with a straight leg raise test, where you passively flex the hip with an extended knee, looking to reproduce or increase leg symptoms, and you can add dorsiflexion and hip internal rotation to that test. Many patients are aware that when they have an episode of back pain, that if that test is performed, that should increase their leg pain. The distracted straight leg raise is when they give you a positive straight leg raise test in supine, that at some point in your examination you have them in sitting and you ask them to extend their knee. This should give you a consistent response to the supine straight leg raise. Patients are less aware. This sitting position test is very much like the sitting slump test, if you're familiar with that. So you're looking for a consistent response to the position of hip flexion with knee extension in both supine and in sitting. Patients that have regional sensory changes, regional weakness, and overreaction to your request to do different things like move around, spinal range of motion, etc., that they give you this overreaction in an attempt to show you how much pain that they're in. So of these 8 tests, if you're seeing greater than 3, it indicates that there might be some symptom magnification or possible abnormal illness behavior. It's important to recognize that this test is not trying to determine if the patient is malingering or faking it or not wanting to get better. You're simply exploring whether there's the presence of abnormal illness behaviors. So some common things that you could be looking at in a more global or general fashion, look at the pain drawing and ask yourself, Does it make sense? Is it consistent with a anatomical basis for their condition? Pain adjectives and descriptions that they use, and as you reflect back on your experience this summer, you may recall some patients that had very interesting ways to describe their pain and their symptoms. That may be suggestive of an abnormal illness behavior. If they have non-anatomic descriptions of their symptoms that you just can't make sense out of, if they have non-organic or behavioral signs, as we've discussed, if they have overt pain behavior, meaning that they're clearly trying to demonstrate that their behaviors or their lifestyle or their activities are significantly impacted by their pain, if they use assistive devices for spinal pain, if they talk about significant amounts of downtime because of spinal pain, if they need help with their personal care, are all considered indicators of abnormal illness behavior. Some caveats for you, though, as you consider your interaction with these patients. Always carry out an unbiased examination. So whether you've met that person in the past or whether you've met somebody similar to this person in the past, always be unbiased. Never come to any early conclusions or assumptions about the patient. And so always observe their behaviors without bias, which can sometimes be really hard to do, but we need to be very careful of not assuming any biases as we observe patient behaviors. Realize that some indicators are common. Or another way to say that is it's not uncommon to see some indicators in patients. So if you're seeing one or two, it doesn't. It's not a significant problem. It's when you start to see several of them stacking up. And then realize that behavioral signs and symptoms do not mean that the patient has no physical basis. It's just a yellow flag telling you that there's more to consider with this patient than just physical. And related to that, illness behaviors are not a diagnosis. They are just something that we observe about our patients and who they are that will impact our diagnosis, prognosis, and intervention. And these really are not lie detector tests. They're just observations of normal human behavior that help us to get to know our patient a little bit better, that may provide us some insight to help us with our interaction with that patient.